Let's talk about Lambert-Eaton myasthenic syndrome. So this is a neuromuscular junction disorder, and the main dysfunction is that there are antibodies against presynaptic voltage-gated calcium channels, and this interferes with the release of acetylcholine presynaptically. These antibodies have a strong association with small cell lung cancer, but they can also have associations with other malignancies such as lymphoproliferative diseases. About half of cases overall are associated with a malignancy. So the dysfunction is in the presynaptic membrane, where the voltage-gated calcium channels normally help with the influx of calcium, which causes exocytosis of these vesicles that contain acetylcholine. So the dysfunction is here. The antibodies will block these voltage-gated calcium channels. This is in contrast to myasthenia gravis, where the antibodies are postsynaptic, and also in contrast to botulism, in where the block is here at exocytosis. So clinical features will include slowly progressive muscle weakness, which improves with exercise, and that's called facilitation. Typically, it's symmetric proximal weakness, and there's no significant atrophy. There can be cranial nerve dysfunctions, of which ptosis is the most common. And one important thing to look for on exam is the reflexes. They are either hypoactive or absent. Strength and reflexes will improve with exercise. Autonomic dysfunction is also commonly reported in Lambert-Eaton syndrome, and this can include dry mouth and erectile dysfunction being some of the most common manifestations. There can be mild respiratory weakness as well, although respiratory failure is not a presenting symptom until late into the disease. Important concepts to know include the diagnosis of this disease, and the EMG will show low compound muscle action potential amplitudes, which improve over 100% after facilitation. Facilitation either meaning 10 seconds of exercise or high frequency repetitive nerve stimulation at 10 to 50 hertz. Low frequency nerve stimulation will not diagnose this disease. Something that is not always tested, but single fiber EMG shows increased jitter. So what is jitter? Jitter is a measure of the difference between the time it takes to activate two different muscle fibers in a motor unit. So for example, let's say that you have a motor axon and an action potential is being sent down. In someone without any neuromuscular junction dysfunction, you would expect the muscle fibers to be activated at roughly the same time, so there will be very low jitter. However, in someone with, let's say, Lambert-Eaton syndrome or myasthenia gravis, sometimes the muscle fibers will be activated at different times. For example, if there's more acetylcholine release at this junction versus this junction, then this muscle fiber will be activated earlier, and there will be increased jitter because these two muscle fibers are activated at different times. Note that conduction velocity will be normal, and conduction velocity is mostly what happens before the neuromuscular junction, so that since there's no demyelination, then conduction velocity is normal, and distal latencies are normal as well. To confirm the disease, antibodies against the PQ type of voltage-gated calcium channels are positive in about 90% of patients. So how to treat this disease? It's by treating the underlying malignancy. So first, to detect it, a CT chest, abdomen, pelvis is a good place to start. And since there's a big association with small cell lung cancer, then SOX antibodies are usually sent. If there's any focal neurologic deficits, then a MRI brain and spinal cord can be useful, and a PET scan can be useful as well in detecting underlying malignancy. As symptomatic treatment, the first line medication is amifampridine, And what this medication does is that it blocks the potassium channel. So potassium typically repolarizes a cell membrane. And so if you're blocking that, then you're prolonging the presynaptic nerve terminal membrane depolarization. So that'll enhance calcium entry and subsequently acetylcholine release. Sometimes tested is that seizure is a contraindication to this medication. Less commonly used medications can include guanidine and pyridostigmine, mostly due to side effects. And IVIG can be useful for refractory cases. For prognosis, the weakness is best treated by treating the malignancy. However, note that it can still persist even after fully treating the malignancy. The lifespan in paraneoplastic cases depends on the stage of cancer. For example, small cell lung cancer, if it's very advanced, then the lifespan will be severely shortened. In non-paraneoplastic cases, the lifespan can be near normal or normal.